All right, so welcome back to our final part of this deep dive into atrial fibrillation. We've talked about diagnosis and management and patient education, using those AI cases as our examples. So last time we were just starting to, look at Emily's case. She's that 62-year-old with some, potential signs of AF. Let's say the GP did the ECG and it did confirm that she does have AF.
Yeah.
So what happens next?
Well, now that we know it is AF, the focus shifts to figuring out how to best manage her condition. And as we've been saying, it's all about that personalized approach, right? So the next step is to really assess her individual risk factors. That's where those two scores we talked about, the CHADS to VAS, getting on the orbit, they really come into play.
Right. Those scores help determine her risk of stroke and bleeding.
Exactly. So the GP would basically plug in Emily's information, her age, medical history, other relevant details into those algorithms. And the scores that are generated, they provide a really clear picture of her individual risk levels for both stroke and bleeding.
Okay, so those scores basically give the GP a personalized risk assessment for Emily.
Yeah, exactly.
Okay, that makes sense. So let's say, hypothetically, Emily's CHADS to VAS score shows that she has a moderate risk of stroke, and her orbit score indicates a low risk of bleeding. So how would those findings actually shape her treatment plan?
Okay, so in that scenario, the GP would likely recommend anticoagulation therapy, to reduce her risk of stroke. But because her bleeding risk is low, it gives them a bit more flexibility in choosing an anticoagulant. Those DOACs we talked about with their convenience and fewer interactions, they'd probably be a pretty strong contender in that case.
Okay, that makes sense. And it's not just about medication either, right? I mean, lifestyle modifications, they play a big role too, don't they?
Oh, absolutely. Lifestyle changes can make a huge difference. So the GP would, encourage Emily to maintain a healthy weight, exercise regularly, limit alcohol intake, and find those healthy ways to manage stress, because all those things can really improve heart health and potentially reduce, how often she has AF episodes and how severe those episodes are.
But what if, despite those changes, despite the medication, what if Emily is still having symptoms that are, really bothering her? Mm-hmm. What are some of the next steps the GP might consider?
Well, if those initial treatments aren't, providing enough relief, the GP might explore other options. They might think about adjusting the medication dosage, maybe adding another medication to the mix, or they might even consider referring her to a cardiologist for a more, specialized evaluation and management.
So it's really an ongoing process, right? It's about, assessing, adjusting, and collaborating with the patient to find what works best.
Absolutely. Managing AF it's rarely a one and done kind of thing. It requires a dynamic approach, with those regular follow-up appointments to monitor progress, address any new challenges that come up, and just make sure the treatment plan is still effective and meets the patient's needs. Right.
So those follow-up appointments are really crucial. And speaking of follow-up, we know that those annual reviews are a key part of AF management. Right. So what are some of the main things that happen during those reviews?
Yeah. So those annual reviews are kind of like check-in points, making sure that everything's still on track and making any needed adjustments. During those reviews, the GP will ask about any new or worsening symptoms. They'll monitor Emily's heart rate, blood pressure, review her medications, making sure the dosages are still appropriate and checking for any, side effects or interactions. And they'll also reassess her risk of stroke and bleeding, using those CHADS to VAS and orbit scores again.
Okay, so it's like a very comprehensive checkup, basically, to make sure that, everything's still going well.
Exactly, yeah.
You mentioned reassessing those risk scores. Why is that important? I mean, wouldn't those scores stay relatively stable over time?
Well, some aspects of a person's risk profile will stay consistent, but others can change, over time. For instance, as people age, their risk of stroke naturally increases, and, new medical conditions can develop, or maybe there are lifestyle changes that can influence risk levels. So by reassessing those scores annually, the GP can make sure that Emily's treatment plan is still, aligned with her evolving risk profile.
Okay, so it's not just a one-time assessment. It's something that needs to be, looked at regularly.
Exactly. It's all about being proactive and staying ahead of any potential problems.
Right. And it's not just the doctor's responsibility either, right? The patient plays an active role too. So what are some things that Emily can do to be more involved in her care?
So the GP would encourage Emily to keep a symptom diary, noting any changes in her symptoms or any side effects from her medications or any other, relevant observations she makes, because that information can be really, really helpful during those follow-up appointments.
Okay, great. So we've talked about Emily in detail. Now let's move on to another one of those AI patients from the GP's video. This time we have John Anderson. He's a 65-year-old man, and he has hypertension, high cholesterol, and valvular heart disease. He's already on medication for those conditions, and he comes in with symptoms of AF that just started like a day or two ago. And the ECG confirms that it is AF. So given that it's new onset AF in John's case, what are some of the key considerations?
Right. So John's case, it presents a bit of a different challenge, compared to Emily's. With new onset AF, there's a sense of urgency, both in trying to pinpoint what triggered the AF and also in starting treatment quickly to minimize the risk of complications, especially, stroke.
So why is new onset AF considered more urgent? What are the specific concerns there?
Well, for one thing, that new onset AF, it could be a sign of some other acute condition, like an infection or an electrolyte imbalance, something that needs to be addressed, right away. And also, because the AF is so new, there's a better chance of potentially restoring that normal heart rhythm, using a procedure like electrical cardioversion.
So it's kind of like a window of opportunity where you can potentially reverse the AF before it becomes a chronic issue.
Yeah, that's a good way to put it. And of course, as with any AF patient, prompt anticoagulation is really crucial to minimize that risk of stroke. And that's especially true for someone like John, who already has those additional risk factors like, valvular heart disease.
So the GP would need to act quickly in John's case, both to, figure out what might have caused the AF and also to start the appropriate treatment, including anticoagulation to protect him from those potential complications.
Exactly. Timely action is really key in new onset AF. The GP would probably want to consult with a cardiologist to determine the best course of action. And that might involve, some further investigations like blood tests or imaging studies to try to pinpoint what triggered the AF and guide those treatment decisions.
Okay, great. So let's look at one more AI patient from the GP's video. This time we have Peter Richardson. He's a 76-year-old man with a history of hypertension, high cholesterol, and he had a previous heart attack. He's currently taking medications for those conditions. And during a routine checkup, an ECG shows that he has AF, but he's not experiencing any noticeable symptoms. So what are some of the key things to consider in Peter's case, given that he has asymptomatic AF?
Right. So Peter's case, it really demonstrates how important those routine checkups are, especially for people who have risk factors like Peter's age and his history of cardiovascular disease. Because even though he's not feeling any symptoms, that AF is still there and still poses a potential risk, mainly that risk of stroke.
So even though it's silent, so to speak, it's still something that needs to be taken seriously and addressed.
Oh, absolutely. Asymptomatic AF doesn't mean no action is needed. It still needs to be carefully evaluated and managed.
So what steps would the GP take to manage Peter's AF, even though he's not having any symptoms?
Well, the approach is similar to what we've discussed before. The GP would first assess Peter's risk of stroke and bleeding using those scores. And that information, along with, his overall health and other medical conditions, would help guide the decision on whether or not to start him on anticoagulation therapy.
Okay, so given his age and the fact that he had a previous heart attack, it seems like his stroke risk would be elevated even without any, current symptoms.
Yeah, you're right. That would definitely be a concern. The GP would have to weigh the benefits of anticoagulation, in terms of preventing a stroke against those potential risks of bleeding complications. And they might also consider doing some additional investigations, like an echocardiogram to assess how well his heart is functioning and see if there are any structural abnormalities that, that might be contributing to the AF.
Right. And it sounds like we've covered a lot of ground today, talking about these AI patient cases and seeing how those guidelines are applied in these, more real world situations. It's
been really interesting, hasn't it? Seeing how those guidelines come to life and how doctors navigate all the complexities of AF management.
Absolutely. And, it really highlights that importance of individualized care.
Sure.
We have one more AI patient to analyze. Sarah, are you ready to see what Sarah's case brings?
Yeah, let's dive into Sarah's case. I'm always interested to see how these AI patients, they illustrate the guidelines in action.
Okay, great. So Sarah Johnson, she's 62, and she has a history of AF. She's also managing hypertension and type 2 diabetes. and she's coming in for her annual AF review. So what are the key things that a GP would focus on during an appointment like this?
Well, with these annual reviews, it's really about making sure that the current management plan is still, working for the patient. So the GP would start by asking Sarah, about any new symptoms or if any of her symptoms have gotten worse, just generally how she's feeling and if she has any concerns about how her AF is being managed.
But it's not just about how she's, feeling subjectively, right? The GP would also be doing some objective assessments as well.
Oh, right. Of course. So the GP would check her heart rate and rhythm, take her blood pressure, and then go over her medications, making sure the dosages are still correct and checking for any side effects or maybe interactions between her medications.
And we know those risk profiles, they can change over time. So would the GP reassess her risk of stroke and bleeding? Even though, we already know she has AF.
Oh, absolutely. Yeah, even though she has a history of AF, her risk factors could have changed since the last review. Her age, other medical conditions, lifestyle changes, all these things can affect her risk levels. So the GP would use those CHADS to VASC and orbit scores again just to get an updated picture of her stroke and bleeding risks.
Okay, that makes sense. Now, what if her scores haven't really changed and her symptoms are well controlled? What else might the GP focus on during this annual review?
Well, even if things seem, pretty stable, this annual review is a good opportunity to reinforce those lifestyle modifications, those things we talked about earlier. The GP would remind Sarah about the importance of, keeping a healthy weight, getting regular exercise, limiting alcohol, and finding healthy ways to manage her stress level.
Well, I think we've reached the end of our deep dive into atrial fibrillation, and we've covered a lot of ground. What are some of the key takeaways that you hope our listeners will remember?
Well, I think the main takeaway is that AF is, it's a complex condition, but with early detection, that personalized management and, patients actively participating in their care, people with AF can, live really fulfilling, healthy lives. It's really important to have that open communication with your doctor, understand your individual risk factors, and really take an active role in managing your condition.
Yeah, absolutely. Great points. Wonderful. Thanks for joining us for this deep dive into atrial fibrillation.